Welcome to the Primary Care Committee meeting. If everyone could please add their name to the chat so we can have that for attendance, that would be good. We have quite the packed agenda today, so we should try to move forward relatively fast. So, Chad, would you like to start us off?
Actually, LJ is going to lead off doing the COVID and back to school, so I'll turn it over to her.
Hi, everybody. Can you hear me okay? Yeah, okay, good. So I'm only going to speak for just a minute or two, and I just figured, I know you have a very busy agenda, but if there were any particular questions that the Adult PCP Advisory Group had, I'd be happy to do my best to answer, and Chad can always join in with that. I think that many of you know that the Monroe County Department of Public Health released their guidance for the moment for a return to school, and it just came out this week. It sort of gave everybody a little bit of a jolt because it completely reflects what is in the New York State Department of Health guidance, and it's extremely restrictive. So restrictive, in fact, that every kid who essentially develops symptoms and gets sent home from school, or who develops symptoms at home and cannot come to school, at this point in time will be required to have a COVID PCR test done and an assessment by a healthcare provider. The other thing that's quite restrictive about the guidelines that's concerning everyone is that even in the presence of, for a child who tests negative, actually has a negative PCR test, the current guidelines state that child has to remain out until they're symptom free. So I'm just putting that out there. If you look at the guidelines, it's very simplistic. It's kind of hard to, there's no real gray zone in any there. It's very black and white. All of this could change. It could change tomorrow. It could change Monday. It could change in a week or two from now. There's been a tremendous amount of lobbying to the State Department of Health, to the governor's office, to the commissioner of health, to look at what is written in the guidelines and understand that in many ways, if the guidelines are enforced, we're going to shut down schools because of the guidelines much more than we are from an outbreak of COVID. So we're hoping there will be some step back in allowing kids to go back to school who have a negative COVID test once they're fever-free for 24 hours and symptoms are improving. That would be one way. That would be a big improvement in terms of being able to get kids back in a reasonable time. For children who have not received a COVID test, that they would have to still be out for 10 days, be symptoms improving, fever-free, et cetera. But that there's some other measure in there, because one of the great concerns is that we're just going to completely overwhelm our laboratory system for testing, at least right now, because of the way the reagents are allocated regionally. So that, in essence, is what we're all looking at. All of us who care for kids, and some of you on this call care for both adults and kids, so you know that. But I recognize there's implications for all of you who care for adults too. In terms of, you may well have people in your offices, your staff, who need to be home with kids now, who are going to be out from school more than ever before. But also in terms of the adults that you care for, I tried to get some specific guidance around what are the guidelines going to be for adults in the schools, for the teachers, for the staff. What's the situation for them? Do they follow the exact same guidelines as children? And the word that I had from the county health department this evening, just before the meeting, they got back to me and said that there has not been, as they've developed guidelines that's been specific to children. They referenced a document for me, which is a interim guidance for public and private employees returning to work. Now, this interim guidance is old, but this is the last thing that they referenced that was put out, which essentially says that for employees who are symptomatic, who need to leave work, if they have a COVID negative test, that they can come back to work, if their symptoms are improving. So it's not as strict as what we have in the pediatric space. And I don't really have much of anything more helpful or hopeful to say, except that, again, we remain hopeful that we might have a better algorithm to work with if the state does, in fact, modify. And there's rumblings that something is going to change. We just don't know if it's going to be both aspects of this that we're concerned about, or if it's just going to be one of them. And then the only other thing I will mention is in terms of masking. We are really trying to get the message out that there really should be only the rarest of masking exemptions, and those really should be for kids who have a severe neurologic disorder where they're really unable to remove their mask if they're not attended to, and where it could provide a hazard to them. That even in instances of kids who have IDD or who have severe emotional disorder, things like that, there really are behavioral plans to be able to move towards masking tolerance. And for a child who can't wear a mask at school, the caregivers and the teachers who work with him and the students around him can be distanced by 6 feet. They can have appropriate protection for the staff. And so it's not a means to exclude a child from school, but that there should be a behavioral plan in place to help that child work towards mask tolerance. It's just not right to consider the IDD population as not needing, or that they don't deserve the same protection, and their families don't deserve the same protection as everyone else. So there's a lot of good information out there. There's a great toolkit from Developmental Behavioral Peds at URMC to help folks work towards masking tolerance. So all of that stuff is on our website. We sent out a boatload of information. We're having a general meeting on Monday, a second summit for primary care providers to come in to talk to the County Department of Health and to talk to infection prevention experts. And so any of you are welcome to that as well, although the focus will be on the kids. So I don't know if folks have questions or if that's helpful information, but I'm happy to try to answer questions if you have them.
LJ, anybody who is one of these people who doesn't want to wear a mask or has an exception, is there any talk about using a face shield instead? And is there any data on that?
Yeah, we asked about that specifically, but both our infection prevention experts and the county health department have said that using a face shield is not mask. So you really have to move towards that. There's the actual mask covering.
That's going to be important for us, in internal medicine, for the teachers and whoever else is trying to get an exemption, to be able to say that specifically. No, it's a mask or nothing, right? So you're good to go, which is really what it should be, right?
Yeah, absolutely. And I just think this is a space where we just had this conversation at dinner with our children who, with having 2 teenagers, like, yeah, wear my mask. Oh my gosh. So, being in all of these conversations all the time, we just had this conversation. Like, I think the medical community should be so loud and so firm and so strong about this now, because everyone has become so much more lax. And if we can open the gyms, for God's sake, we should be able to open the schools, and we should all be responsible.
I think along that same lines, Diego, there's been some mention, and maybe some of you guys have run into it. There are those who are looking for exclusions. I have asthma, I have non-oxygen dependent COPD, whatever the case may be. Then there's also the mention of some people who want N95s and want to be mandated that they wear N95s because they teach PE, they have kids that sneeze or cough or whatever. So there really is no indication for an N95, but they must wear a mask. And I don't know that schools are going to have supplies. I can almost guarantee they will not have supplies of N95s. They will have supplies of masks. So, I think if on either end of that spectrum, pretty much the answer is no.
Right. And as a medical community, we have to stand together on that, right? So that's the important part.
Yeah, I totally agree.
Any other questions for LJ? Well, thank you very much. Appreciate the update.
You are welcome.
All right.
So moving on to Dr. Teeters for your population health scorecard.
Yes, I'm going to do a little bit of a different dog and pony show tonight. I'm going to share my screen for a moment. Can everybody see this metric performance? See a bunch of colors? Yes, okay, I see nodding heads, that's good. So, we always show you guys the dashboard, which shows the speedometers and shows how we're doing in adult preventative, peds preventative, chronic disease management. So this is actually the real performance in the scorecard. Ooh, extreme close up. Get everybody sick for tonight. So I'm going to go ahead and say this is thanks to Christy. This is a little bit of a abbreviated version of what she sends out to us within the leadership team of AHP, where we follow our performance for all of our contracted metrics. So the metrics that you see on the left side of the screen are the metrics that you would see if you logged into Arcadia today. This is for the AHP network as a whole across all 3 lines of business. So this is not practice specific. This is not any subset. This is all of AHP melded together for commercial, which is column B, Medicare, column C, Medicaid, column D. At the bottom, row 19, you'll see contract points achieved. So out of 100 points, how many points have we achieved? For those who are playing at home, you will look at the Medicaid column and say, holy crap, that's a lot of red and pink, and somehow you got 72 out of 100 points. 1, we're pretty good at this. 2, we also were able to contract around some collaborative points for some of the health improvement and cost reduction initiatives like readmissions and some of the other projects that we've been working on. So we get points for those as well that contribute to our overall metric performance. The purpose of me showing you this is to kind of highlight when we're reaching out to you guys and talking about what metrics are we as a network kind of focusing our attention on for the rest of this year. As you can see, we are at and above 90 points. Once you reach the 90-point plateau, that gives you the highest percentage gain share and the lowest percentage of any loss. So if there's a savings, we would get the highest percentage, which is roughly about 75% of any savings incurred. If we score above 90 out of 100 points, then we will only be held to 25% of any loss that we incur. So these points make a difference. And roughly for every 10 points you lose about another 10% share. So we would only get 65%, we would owe 35%, and so on and so forth. So as you can see right now in commercial, with still 4 months left to go on the clock, we are already above the 90-point threshold. So in the commercial grid, we are actually doing very well. And just by law of attrition, we are likely to pick up some extra points in the commercial space, which is why we are not harping on you guys about commercial right now. You will see that the same metrics we're going to talk about in Medicaid are also those that need help in commercial. So it's no small feat when we pick these things. In Medicare, we are at 80 points achieved right now. It's actually 79.5, but I rounded up a half a point. When you look at some of these, it is likely during normal course of business that we will close the gaps in some of these metrics to achieve the next threshold. Breast cancer screening being the one where I'd say very likely we will move from 75th to 90th if we close gaps at a normal rate. Now, I have to admit, if we have a second wave of COVID and we go against any non-essential testing and the radiography suites close, that could inhibit our ability to close some of those gaps. So all of this is based on no significant penetration of COVID that would require us to go back to a March, April kind of course of business. But you can see the diabetic measures are still lagging, even in Medicare, but we're at 80 out of 100 points. I will tell you, see, you would ask, why is it that we are not pushing the envelope right now on trying to get above that 90 points on Medicare? The reason why is, as of right this moment, the anticipation is that our total spend is about $26 million less than our budget from last year. So we have theoretically a $26 million savings in Medicare alone. Our Medicare contract limits our earnings at no more than $4 million. So at 80 points, we would get 60% of any gain share, which means we would be due $13 million, but we cap at $4 million. So there's really no contractual value of trying to beat everybody's head against a wall to close those gaps. But when we work on closing gaps in diabetics, it's because we think it's good for the health of our population, not because there's a need to strive to close, check this box to improve our contract performance. So Medicare, we are fine. Even if we stop today, we will achieve our maximum gain share most likely, but we're doing it because we care about the health of our diabetics and we want to make sure they get the care that they deserve. Influenza, you can see we're below the 25th percentile, but it's, we're just now getting into flu vaccination season. So that one will naturally move as the season wears on. So that's not a terribly big surprise. Medicaid, you can see lots of red. Some of these things, it's just almost impossible. So I'll highlight well child 3 to 6 year. We basically paused all the well child 3 to 6 visits because they were not in the essential category for a period of time. And it's hard to make up 2 or 3 months of lost time to backtrack and close all those gaps by year's end. As much as we think it's important, it's still unlikely that we're going to see a 90th percentile performance in that metric this year. So the metrics that I've asterisked, so starting from the bottom, lead screening and childhood immunizations in the pediatric category, the 3 diabetic measures, diabetic eye exam, A1C less than 8, and diabetic nephropathy screening, and then colorectal cancer. Those are all the metrics that we have decided to push forward on this year, not because we necessarily need it for contractual performance in commercial and Medicare, but because we think A, those are important healthcare things, and B, in many of those metrics, the number that we need to achieve to reach the 90th percentile is actually very low. So our greatest chance of gaining points is in those metrics that we asterisked. So I just wanted to show this guy to you guys tonight just so you get a sense of where we stand. You're probably also aware that we do have this by trailing years. So we look at the rolling 12 months that are rewind from today. That is also skewed this year because COVID was thrown in between. So it's hard to interpret the trailing year this year in comparison to other years because COVID threw off that normalization. So the only way I can do it and do it fairly is if we stopped today, this would be our metric performance in our 3 lines of business and would determine what our gain share looked like. We are still doing very well. It is likely we are still going to perform very well financially in all of our gain share contracts this year. But from the population health standpoint, those asterisk measures are the ones that we're going to continue to work towards and focus our attention on because we think those are going to be important. But that being said, we've already generated some chase list to your practice around diabetics. We're rolling out our IRIS program for diabetic eye screening for those practices who partnered around that. LJ and the pediatrics team have been working for a long time with the lead screening and the practices that were implemented with point of care lead screening. So we're not necessarily handing you guys bunches of chase lists because we realize that you've got lots of things on your plate right now. Unfortunately, this is showing you essentially 3/4 of the year done. There's still 25% of the year to go. And in some of these metrics, we're talking as little as 100 gaps or less that would move us from the 25th to the 90th percentile. So it's not all as doom and gloom as it looks like in the colors. Some of this will actually improve quite nicely by year end, and it'll be the color bars that we're used to looking at. But those are the ones where we think we have the most benefit and potential for contractual point gain. So any questions about this? I realize that's a whirlwind tour of metrics in a moment.
I had a question.
Oh, please.
What are the immunizations in the childhood immunization combo 3? What is that referring to?
I'll let the pediatrician, because if I do that, I'm going to miss at least 7 of them.
Is it
It's
just
really
all of them?
It's really the vaccines in the primary series, so your Tdap and your IPV, your Hib, polio, MMR.
All of them.
Now that, yeah, so essentially all of them that you would have up through age 2. So, and to be honest with you, again, because I like to blow the horn of all of the family med docs and the pediatricians and the med peds docs who work so well. It's remarkable that our immunization rates in that age group are where they are, because many communities are reporting less than 50%, not percentile, but less than 50% of kids are up to date on those combo 3 immunizations right now. So it's a tribute to how hard everybody worked to prioritize kids in the pandemic.
Any other questions folks have about the metric grid as it currently stands? Okay, so our next meeting is for the end of October. So obviously this will look a little bit cleaner as we get towards that next PCP advisory meeting. So we'll update you on how this looks. But, you know, I would not anticipate hearing any additional late season rushes from us. We're kind of, you know, we've done a lot of work. Elizabeth and her optimization team have been looking at this. When I say 100 times a week that we change our plan, that would be an underestimation of exactly how many times Elizabeth goes through this. So know that we are trying to be as attentive to the fact that you guys are being pulled in 1,000 different directions, but also in a year where there's going to be a lot of value-based gain share on the table, we don't want to leave dollars behind and just bequeath it to the payers, because, you know, this could have big implications for all of the practices in the network. So we want to grasp everything we can, but not ask you guys to go over and above when you're already going over and above with thin staff that's overworked already. So we're trying to balance the stress as best we can. All right, so moving on, we will go to gain
One
share.
thing, Chad, before you go on, for anybody who joined the meeting and hasn't put their name in the chat for attendance, please do so we know that you attended the meeting. And we'll go ahead with Chad for the 2019 gain sharing.
Yes, so the part that everybody likes, which is the dollars, and I'm going to let Kevin take over the share screen now. So I'm actually playing Renee Sutton for this presentation. So everyone knows that it's about this time of year where we get all of the final payments and the reconciliations from the payers on our 2019 or last year's performance, and then we pay out the gain share. So many of you, because you gave your, I'd say most of you, because you gave your bank transfer numbers to Jim Wright, have already seen the money flowing into your practice accounts. And so you should have received a letter dictating how those funds were earned. But we just wanted to review with the entire network what this looks like today. So gain sharing contracts, again, this is what AHP exists for. This is on top of your fee for service billing that you get already. Everyone understands how this works. So we have a budget set usually by the preceding year's spend. And then we have to beat that budget and achieve quality scores on the metrics like we just looked at for the population that is attributed to that particular contract. And that's how we earn the money. If we spend less than we were budgeted and we are doing well in our quality metrics, then we can achieve that 75% of share of any savings that were earned. This is separate money from those clinical integration or that per member per month payment that comes out. So this is money that is earned because of performance, not just because of attribution. I just said the last piece. And then basically all dollars, you know, we'd love to say that we get 100% of it, but even under the best circumstances, 25% stays with the payer, 75% comes to AHP. And this is the best part of working at AHP. Well, the worst part, we don't get any extra bonuses, but the good part is we get to play Robin Hood. So if AHP does its job, we should finish the year with $0 in our bank account because we're a taxable entity. And so we do not want to pay any corporate income taxes on any retained earnings. So all the dollars that come in get passed out to the network and back to all of you. Next slide. So contracts where we had shared savings. So these are all the contracts where we actually earned money this year. Fortunately, I think we only had a small loss in one contract, and that was the UR Medicine Health Plan, which has actually been up for renewal this year. So we've had some issues with that one that we are looking to rectify in this renewal. So hopefully that will contain any risk of loss in the future. You can see the Excelis commercial, the MVP commercial, and the Highland Hospital employer plan were all plans where we earned gains, and that is what the gain share that we're getting ready to show you is paid out from. Understand that there are other lines of business, Medicare, Medicaid. It is not that we incurred a loss on those contracts, but there are corridors where you have to exceed a certain amount of savings before anybody earns or pays dollars. And so we were inside those corridors in most of these other contracts. So it's basically a no harm, no foul, no money lost, no money earned in those contracts. And you know, this was a year where we knew going into it, and we talked about before, specialty pharmacy accelerated at a rate unanticipated even by the payer actuaries. And so most of our curtailing of spend was not because of, or curtailing of earnings, I should say, was not because of not decreasing spend on the medical care side, but rather it was the specialty pharmacy drugs that really drove us into a loss situation in most cases. The payout, this has been agreed to before, so as we always say, we agree going into the year, we take it to the membership committees and the boards, and the board, I should say, for approval. So we would not change halfway through how we're going to pay out. So this was what was approved at the end of 2018 for how 2019 would be distributed. So 60% of the earnings go to the primary care physicians, 24% go to the specialists, 15% go to the hospitals, and then 1% goes to the non-equity, which includes some of the nurse midwives, physical therapy, podiatry, and home care. So that's the distribution. The large S goes to primary care because most of this money is earned on the backs of quality metric performance and primary care performance. So no change here from years past. Next slide. So how did we devise this? So there are 3 tiers, if you will, to how the payment gets paid out. Everyone gets a base payment. This is the participation trophy. So you cannot earn less than $2,100. There is then a dollars per member payout. So there's an attribution component to it as well. So you get $2,100 and then $3.95 per attributed member that you have from your practice to these contracts. And then we divide the quality out into 3 tiers. So bronze tier is those who scored less than 65% of possible points on their quality metrics. Silver is 65 to 89% of possible points achieved. And gold is 90% or higher points possible achieved. And you can see how much incremental you get based on your quality performance. Go to the next slide. So specialists just get a flat rate. This is, I believe, a little bit lower than what it has been the last couple of years, if I remember correctly. So all specialists that are members of the network get a flat $1,220, and that's what constitutes their 24%. So there's no incremental payment for performance or other at this time for specialists. And the non-equity, those are relatively small numbers. So again, this is our midwives, podiatry. Those facilities get a flat $1,000 membership fee, or I'm sorry, gain share payment. But again, no earnings of over and above that for quality or the like. And then the non-equity participants, so these are the ones who are not fully participating in all the contracts, they get a flat $700 membership fee for participating in some of our arrangements. So, as we said, for those that have electronic transfer, you should have already received these funds. Jim Wright, our CFO, mailed out checks to the rest. So I believe, and I think Jim's on the call, so he can hold me accountable if I'm wrong. But I believe everyone should have received your gain share funds at this point. If not, please signify by saying aye shortly. And then the specialists and non-equity will be receiving their funds at the end of September. So coming up in the next couple of weeks. Jim, I see you flashed yellow. Is there anything you want to add or change from what I just said?
Sure. I'm going to add a couple of things. First of all, the specialists are getting more this year than they did last year slightly because the overall gain sharing is up this year over last year. Yeah, everybody has been paid on the PCP side, and pretty much not only have the electronic payments gone out, the checks have gone out, and pretty much most of the checks have been cashed. So the money has gone out. One thing just to clarify in all of the conversation, all of the slides, when you talked about the couple of plans that had a loss, I believe everybody, we've talked about the AHP insurance company and that, we do put money aside. So like we don't apply a loss against your gain sharing. So it's not like we have positive gain sharing and then have to pay back out of that. The AHP insurance company where we set monies aside, that's where losses are covered. So we talked about that in the past and just to make sure we clarify on that.
Right. That's a good point. Any questions that anybody has about any of that? All right.
Okay.
Great.
So next up on the agenda would be Christy with the Arcadia update.
right, let me just share my screen. I'm going to take a couple minutes to take us a quick tour through the Arcadia system and a few of the changes that you'll be seeing. Okay, can everybody see my screen? It says Arcadia Upgrade August. All right, so the beginning of August, we took a very large upgrade, and part of that is a little bit of look and feel change, some functionality that's going to benefit our care managers, but for the most part, what you're going to be seeing is pretty consistent with what we've had in the past. So I'll take you a quick little tour through here. Just a reminder, when you log in, you can get to our Arcadia login page from the AHP website. I think some of you may go in there more frequently than others. So it's an easy way to remember where to go. Click in there. If you haven't been in and logged into the system in over 6 months, your account disables. So you would just need to contact us at AHP, our help desk at ahpnetwork.com, and we will re-enable or activate your login account. If it's the first time you've logged in after the upgrade, you need to click the forgot password because there's new credentialing system behind it. And also, when you do change your password and get the account activated, you're going to need to use all lowercase for the username. That's a change, and it has caused us some troubleshooting issues with some of the people that aren't used to using all lowercase. When you log in on the first page, one of the biggest changes you'll see is there's, we call these little widgets, and it's a quick link over to the AHP website where we have put user-friendly definitions around the measures. We're trying to make it easier to find them and also more user-friendly. So when you click on this, it's going to drive you to the AHP website. There's a link for every single measure, and there's also a little link here for all known issues. So you can go one place and see what's going on. If there's anything that you think might be a little suspicious, we would say go look here first. This is an example of what one of the web definitions is. They all have the targets on the right-hand side. The thresholds for this year are listed, but also how much they changed over last year. There's a description, and this piece here is really important, the changes. We want you to know anytime we take an upgrade or a new year definition, what are the changes? What's going to be most important for you to be aware of? And with this upgrade, we did take a more population health friendly version of our measures. So really now, if anybody is active in your EMR, you're going to be seeing them if they qualify for the denominator. Prior to this, there was some more health plan focused type definitions that were really requiring a patient to have been active in a certain period of time before they counted. And those sometimes skewed the population that you were seeing. You weren't seeing everybody that you knew had diabetes or everybody that you knew had hypertension if they weren't active. There's also a click here for known issues around this particular measure. User-friendly information around what's in the denominator, numerator, and then it goes on with a couple of other things that are important. The known issues, it's an example of what the colorectal cancer screening issues were. Tells the date that we've identified the issue, a little bit about what it is, which is the measure, and then what EMRs does it apply to? Because sometimes it only applies to MedEnt or ECW, or maybe it's everything, and then what's the status? These are older ones, they were already resolved. So back to the Arcadia application. So when you first logged in, I took you right away over to the definitions. You're going to, in order to see your performance, which is going to be what's most important to you all, is click on the performance menu at the top. And then there's 3 options here. The Aqua IPP standard, which is all measures. The adult is the adult only measures, and the pediatric, which is the pediatric measures. When you pick one of those, you're going to go into that measure page. This one is the Aqua IPP standard. There's a little flyout over here. If you click on filters, you can change the period that you're looking at. But what's nice about this version change is that now you don't have to keep going into filters to see what period you've selected. You can see at the top here a little breadcrumb. So here we're seeing trailing year August 2020. And trailing year is the 12 months look back. So this would be September 1st, 2019 through August 31st, 2020. If you switch to a year, 2020, you're going to be looking from January 1st, 2020 to December 31st, 2021. So seeing how you're progressing with this year's measure performance. And because we've looked at Aqua IPP standard, we're looking at all 14 measures. So there's a little 14 in front. 100 points are available. And for this particular practice, they've captured 46.25 already. So they're 46% of their points. So this is really that percentage that determines whether you're in bronze, silver, or gold. So it depends on the specialty. If you're family medicine and you're doing both adults and children, you're going to be looking at the Aqua IPP standard. If you're an adult or internal medicine only, you would be looking at your adult view. And just a real quick overview of what these pages look like. The measures are listed down below. They're always sorted with the one you have the fewest people that you need to get to the 90th. And you can sort on any one of the columns. You can go alphabetical. You can look at points earned, put this in any order that you like. The blue line indicates which one is selected. And then that's what you're seeing over here on the right-hand side. And so change over time. This we're only seeing from May through to current month. And that's because the measure definitions changed. And so Arcadia can't display the older definitions any longer. Now we have history and we're going to be working on getting you some historical views of these things. But within the Arcadia application, you can only look at the current measure from the point that we changed over and calculated it. Underneath here for this measure, the childhood immunizations, there's a provider comparison and I've blanked out the names. It shows the one who has the fewest number of people still to complete to the 90th percentile, and it goes on down further from there. And then at the very bottom, there's another little score card that you can go in and actually click on view all gaps, and you can see all the patients that need to have something done in order to close that gap. You can see what your upcoming chances are this week based upon appointments scheduled, and then anything you may have missed just recently. A couple of quick ways to get in. And then this is a look at what the adult looks like. There's only 9 measures, so only 61 points available. Everything is exactly the same kind of look and feel. And then this is the one for the pediatrics where there's 6 measures, 39 points, and everything else is pretty much the same. Any questions? Okay, well, if you have any, you may always email us at helpdesk@ahp@ahpnetwork.com. That goes to myself and Willie. We're always available to help troubleshoot anything that doesn't look right or answer any questions.
Great. Thank you very much, Christy.
Welcome.
Steve, again, before Steve starts, anybody who joined the meeting, please put your name in the chat so we can have you down for attendance if you haven't done so already. Steve, would you like to take the next agenda item with the practice absenteeism issue?
Absolutely. So I just thought it would be helpful to bring this up as a conversation just so people can share with each other what they're thinking, what they may be doing. There's obviously concern in many of our practices as we head into school here unless your kids are going, or your staff's kids are going to one of the few private schools that are going to be full-time in school. Mostly schools are either not going to be open or for in-person learning, or it's going to be a hybrid model where kids are in school probably 2 out of 5 days. So this is going to be a burden certainly on young physicians, APPs, but I think it has the potential to be a real burden on our staff, more for financial reasons than anything. I know in our primary care network, we've surveyed our practices, and there's probably about a third of our practices that have significant concerns about staff needing to be home with young children when they're not in school. That's going to clearly conflict with being able to work in the offices. We're trying to brainstorm ways to provide people with alternative hours. I'm certainly happy to share some of the things people are thinking about, but I thought it would also be helpful to hear what some of you may be thinking about, because I know this isn't unique to employed practices. So, we're talking about whether or not we can have, in some cases, evening hours or weekend hours. Those may work better for some staff. We're running into an issue at the university with that, where there's issues around paying overtime right now, so there's challenges there. We are very much looking into allowing staff to do maybe 4 10-hour days instead of 5 8-hour days. If that'll help, we're looking at providers doing more dedicated telemedicine sessions going into the fall, which theoretically require less staffing. Those are just some ideas that we're hearing from our practices, but I'd love to just open up the floor and see if people are particularly worried or what people are thinking about doing. Maybe.
I'll share our practice. So, we certainly have some concerns with some of our nursing staff that they may have to be home with their kids. It happened toward the end of April and May there as well. So we're trying to, cross cover each other and utilize other staff. We're actually going to have a gatekeeper at our front door as opposed to the runner model that we have right now going to the car. So we have people actually enter the building now, and then the gatekeeper will do the temperature and the screening questions at the desk. And then hand off to a nurse for each individual doctor, or if we have to share staff to the nurse that's just going to be able to put people in rooms for us. In terms of the secretarial piece, we tested a system to be able to have the secretaries work fully from home, which is still probably difficult if you're trying to have your kid do school and mentoring them at the same time, but still they can perform their job from home with one secretary in the office sort of being the hands-on for the things that have paper and pencil stuff at the office. That's preliminary for those two things. We have other, little ideas for, future appointment scheduling, things like that, so people don't have to sign out the window if we're really short on staff. But those will be unrolled if they're needed.
Diego, what are some of the secretarial things that you're seeing thinking that people might be able to do from home? Because we certainly, we're struggling with that. Certainly they can't really answer phones. They don't have necessarily access to fax machines, et cetera. What type of stuff might they do?
So again, being private, we have a little different system than you do, but we actually can transfer our phone from the office directly to their cell phone. And so it can go directly, and they can use their phone as the office phone. The only problem is you can't put phone calls on hold. That's the only issue. So their voicemail sort of becomes the hold. You say, please leave a message and I'll get back to you. So there can be a slight backlog in calls. It wasn't traumatic when we did this in April, but the secretaries had said that was the biggest downside. The other piece you asked was in terms of faxes. So there's an app that you can use on your cell phone that can create a PDF file that you can email. So for $3.99 a month, you can create a document and then write something up, and then with that PDF be able to send it to somebody's email, so you can send things to patients or to other locations.
Yeah, all of our secretaries and all of our nurses are set up to work from home, so we could get by with very few people in the office. And we've actually had to do that, on several occasions where people have had, situations where a family member has had symptoms and they've had to be in quarantine, and work from home.
So do they have access to the electronic health record at home, or?
Yep. Everybody has a laptop that they can take home and work from home. They have the phone system is all connected. So they can, just like they said, it's as though the office is at their house.
And your offices provide them with laptops?
Yep.
You have office laptops. Okay. Other ideas that people would like to share? Those are both really helpful to me to hear. I know some of this is a little bit of play it by ear, but.
Yeah, I can say this is not primary care, but certainly within cardiology, this actually worked well for our group. So amongst our sonographers and our nurses and our clerical staff, those who had young kids, they actually took turns and kind of served as babysitter / supervisor. How they socially distanced, I'm not quite sure, but they worked it out amongst themselves. And that was the solution that they kind of preferred early on in the early days of the pandemic. So we had 1 or 2 that were out instead of the 25 or so that were in those categories. And a lot of them live close to each other. They're friends outside of work anyway, so their kids knew each other. So they did that. They liked that approach, and that worked better for them. So we just kind of had 1 or 2 out on a rotating basis, and they would kind of take turns with it, and that worked pretty well. The other thing I will mention, in case folks were not aware, the YMCAs are now planning to open up both extended childcare, but also remote school mentorship. So at least the kids will have a place where they can be supervised for parents who must go to work. The Strong Museum of Play is also doing a very similar remote learning mentorship program. I don't know how much education it will be, but there will at least be somebody there to kind of help oversee and assist to some degree. So there are more of those things that are popping up. The county the county commissioner, the YMCAs, all of those groups are kind of pulling together to try to see as we get closer to the go live of school if those things can be recreated. I don't know much yet as far as the cost of those things. I realize that some of our staff who may need that the most are the ones who could probably afford it the least. I don't know of any free services in that realm that are being offered. I know the U of R and I believe Rochester Regional have been talking about creating something for their employed providers and their families as well, but I think that's still in development on both sides, to my understanding. So there will be some other options for childcare, but probably it'll come with a price tag that may be difficult for some.
There were a couple of chat comments here, just that
I saw that from Sandy. So I use a URMC email for things within the system, which is a HIPAA secure. So that's within the URMC system. I have URMC email. If patients need a document of some sort, if they send an email saying that they allow us to send them an email, then that satiates the HIPAA requirement. So if a letter needs to be sent to them or a lab slip and they want it, as long as they authorize it, then we are able to send them that email.
All right.
Steve, we were thinking about doing that after hour thing you were talking about at nighttime and weekends. And we had, back in April when things were not sure which direction was going, we had a plan to sort of keep only 2, maybe 3 doctors in the office and then rotate nighttime or weekends if we needed to kind of create an urgent care model in the office. We never had to go to it, but we did have that in place, which could come up again if it came to that, so that we can rotate people in at different times.
Great. Well, thanks. Thank you, everyone. I think looks like conversation's dying down on that. So thank you.
Great. I can't believe we made it through that agenda with time to spare. That was fantastic. Chad, any further things you want to bring up before we call it an evening?
Yeah, if I can just kind of poll the audience. I did this on Wednesday as well, but we've been having a lot of conversations about flu vaccination and potentially some decrease in access that could occur. So, as many of you may be aware, there is some of the community pharmacies, I would love to tell you which ones, certainly the smaller ones it seems, that have decided either because of staffing and or social distancing that they will not offer their flu vaccination programs this year. We know that some of the employers, it does not sound like the large employers, but certainly some of the small and moderate sized employers that are either on furlough or for financial reasons have chosen not to maintain their contracts with the wellness companies that come in and do flu vaccinations for employer groups. We also know that there are many VIEW and clinics that are not going to be able to offer drop-in flu vaccination clinics this year because of staffing and just physical plant restrictions and the like. So I'm trying to get a sense, obviously we don't want to duplicate resources. We know Wegmans is doing a lot of effort to extend even above and beyond their normal flu vaccination component. We've had some discussions internally that there's going to be some efforts led by the School of Nursing and the U of R Wellness folks from the URMC in partnership with the YMCAs to offer some flu clinics at some of the local YMCAs within Monroe County. So we will have some new vantage points. Even Trillium, Erica had mentioned that Trillium is going to be offering some flu clinics that they're going to open up to the community as well. So I'm trying to get a sense of what's the deficit compared to historical amount of flu vaccination that's available versus what are the outreach efforts that are already underway, and is there a delta that we need to fill the space? Because my biggest fear is that, one, we're trying to avoid the twin-demic concern of an unvaccinated population getting flu at the same time COVID rears a second wave. But we also are trying to potentially get ahead of the game of if we get into a situation where October, November, we, God forbid, have another big wave of COVID and we have to pause non-essential visits, and then access to flu vaccination within the practices diminishes. It's going to be very tough to stand up an access plan in days. So I'd rather do it proactively now, have it sit in a shelf and never pull it off if we don't ever get there. But at least try to be a little bit proactive and kind of setting up some logistic planning so that if we need to do that, we can do it on a moment's notice. So I just want to get a sense from you guys, are there any of you that feel that you're going to have a deficit in your population, or you're already noticing? I see, Steve, I know you've already answered that question, so you don't get to answer twice. But or do you feel like there's a need? And if so, do you have any ability to quantify that need? And if the answer is we haven't thought about flu vaccination because there's 1,000 other things to get to before that, that's okay.
No, so Chad, so our practice, we've received already 25% of our allotted vaccine for the year. We've actually started vaccinating people. We order flu blocks, so I feel confident that the younger population gets something that actually will carry them through the season, as opposed to the Afluria, which Wegmans is giving, or some of the other flu cell vax, right, which have one-time antigen. We're actually going to get 50% of our 50% more of our flu vaccine in 2 weeks, and we're having outside clinics. So we're actually getting a tent put outside our office, and we're going to block off part of the parking lot, and we're going to have a drive-through service where people come in by appointment, and we're going to vaccinate as they go through the tent that we have set up out there. And then depending on how that flu clinic goes, we have then a week later, the last 25% of our flu vaccine coming. And we've been able to pre-order another 300 doses after that, so just in case, seeing what the need is.
Okay.
And trying to do it before the weather gets bad, because that tent idea doesn't work in November.
Yeah.
Potentially.
We have considered the same thing.
Yeah.
Anybody
Is anybody else worried about the giving the young people this Afluria and flu cell vax in August and September?
Yes.
Trying to encourage the younger people to hold off a bit.
Yeah.
Is there a worry about vaccine supply, or is it just, Chad, that there's staffing issues and it's going to be the shortage, it's just getting it distributed?
Yeah, it's a good question. So this year, interestingly, because of all of the groups who would have pre-ordered in February but have now reneged on their orders, there's actually, for the first time in my recollection, there's actually an availability of flu vaccine at primary market price. So oftentimes at this time of year, if you want to get more flu vaccine and you've already gotten your allocation, you have to pay a secondary market price, which is usually a little bit higher, and it's restricted as to how much you can get. Now I think there's enough of the manufacturers actually worried that, you know, some of the big contracts that they had through some of these wellness groups or pharmacies are not being fulfilled. And so they're trying to actually move the vaccine a little bit. So we actually have sourcing allocation. So I don't think that's going to be a problem. You know, there is a lot of thought that there's probably going to be more people seeking flu vaccine than ever before. You know, there's other people who will, you know, everybody's going to be wearing a mask. They probably won't want it this year because their likelihood of getting it's going to be less. But I don't know where the truth is going to lie between those two. But for right now, I think people are at least aware enough that there's probably more people seeking flu vaccine than normal, I would guess. So I do think there's more supply. I think there's going to be more demand. I think there's going to be less availability of administration.
But the mask works for flu and COVID.
Exactly.
That's the most important part.
The only clinically proven thing that works for both.
Absolutely.
All right, so I mean, I don't want to belabor this point, but you know, it's something we're going to be thinking about again. It may be something that sits in a drawer and never gets mobilized, but we're at least putting some logistical thought to it so that if and when we need it, we have some options of how to stand that up fairly quickly.
Okay, well, with that, if we're all good, any other further questions or comments? No? So the next meeting will be in October, the 22nd at 7 p.m. So thank you very much, everyone. And you've got 6 minutes left of this hour that you didn't anticipate having.
Thanks a lot.
Thank you.
Have a great
Good night,
night,
everybody.
Take care, guys.
Thanks.